Good morning, everyone. We are very glad that you all could join us today. My name is Tara Britton. I'm the Director of Public Policy and Advocacy at the Center for Community Solutions. I'm joined by some great colleagues and speakers today to talk about what has been on all of our minds since June 1st and before, is getting a better understanding of the interim final rule that was issued by the Centers for Medicare and Medicaid Services at the federal level around Medicaid work and community engagement requirements. This is something that stemmed from HR 1, One Big Beautiful Bill Act, whatever name you have so chosen to call it, that was signed into law last summer. It has now been a year. It was July 4th of 2025 and requires for the first time work requirements in the Medicaid program. We have been waiting since that time to better understand how those will be implemented. The guidance that came from the federal government on June 1st answered some questions, but then created a lot more. And so we're going to talk today with some experts in the space around what work requirements mean, what the interim final rule says to the best of our understanding, and then the sort of putting into motion the action of providing comments on this interim final rule at the federal level. Those are due July 31st. So we are hoping the timing of this webinar in mid-July helps to inform the process that you all may take to provide comments to the federal government on this interim final rule. There are lots of details. It's many, many, many pages long. And we wanted to equip you all with some information and also uh, kind of help navigate the process of providing comments that will speak to the I don't know, concerning, but also things we have the most questions about as it relates to implementing these work requirements. We know that our partners around the state are most equipped to talk about how these changes impact folks who receive Medicaid coverage, receive health services through Medicaid. All of you who are actively hearing the experiences of Ohioans and how these big policy changes, big complex policy changes are being felt by the people who are experiencing them. That information, that experience is really important to inform the comment process. And so, with that in mind, I will introduce our speakers. We'll give a little brief, you know, lay of the land here. We are recording this webinar. It will be on the Community Solutions website after probably later today. It usually wraps itself up pretty quickly and we can get things posted. We have a lot of resources that Community Solutions has produced on this issue over the last year, as we've been kind of digesting what is in HR1 and how it will impact the Medicaid program. We also would love to share the resources from our partners at Families USA. One of our speakers is joining us from our national partner there, and lots of resources that they have been putting together around providing comments, but also kind of all of the intricacies that we've been dealing with as it relates to Medicaid changes over the last year. I will also say that we should have a pretty robust discussion session later in this webinar. We want folks to be able to ask questions. Don't be overwhelmed, or you can be overwhelmed. Maybe we all are a little bit overwhelmed by the amount of detail that we're seeing on some of these slides. We will share the slides along with the recordings, but also be prepared to ask questions later on in the webinar, because we know that it's a lot and there are still lots of details that we're working out. And we want to highlight those in this comment process to say, look, this isn't clear. We need to have clarity to implement this. So that's kind of what we're working on here today. So come prepared for the end with questions. So I will introduce our speakers. John Corlett is a former Ohio Medicaid director, also former executive director of the Center for Community Solutions, and joining us today as a visiting fellow on Medicaid for Community Solutions. He will kind of provide some background on what we're dealing with here and help us better understand the interim final rule. I also would like to introduce our speaker, Jesse Cross Call from Families USA. We have worked with Jesse for a long time in many different roles and capacities on wonky health policy. So we really appreciate him joining us today to help all of you and us better understand as we kind of move into this critical commenting period on the interim final rule ahead of implementation. So feel free to drop questions throughout. We can keep track of those. And I'm going to turn it over to John to start the presentation.
Thanks, Tara, and thanks to Community Solutions for hosting this webinar today. I think it's a really important topic. So let me attempt to share my screen here. Okay, I hope that worked.
It did. Thanks, John.
Thanks, Tara. So I'm going to kind of go over just the basics of this because I think it helps to just start with kind of a basic understanding of sort of who we're talking about with these new sort of what they call community engagement or work requirements. And first is just who's in this group 8 that we hear referenced, and it's generally Medicaid expansion adults. They're generally adults ages 19 to 64, not pregnant, not eligible for Medicare, and have incomes up to 138% of the federal poverty level. So I also think it's helpful to talk about when we talk about these requirements to sort of start first with who doesn't have to meet them based on the law and the rules. And so I'm going to go through those. And the thing I would say about some of these is with some of these, there's a bit of nuance behind them. And there, as with all things Medicaid, there's always a lot of details, but I'm going to sort of stay at a higher level for the purposes of this presentation. So who doesn't have to meet the community engagement requirement? First is current or former foster youth under the age of 26. Also, Native Americans, urban Native Americans. I don't know that we have California Native Americans in Ohio, but people who are otherwise eligible for the Indian Health Service. Another category that doesn't have to meet this requirement are parents, guardians, a caretaker relative, or a family caregiver of a dependent child aged 13 years of age or younger, or a disabled individual, caretaker for a disabled individual. And it can also include someone someone can be exempt if they're taking care, providing care to someone in another household, if the care provided is significant. And so there's a lot of detail about what counts as significant generally, but we can go into that more later if somebody needs more information on that. Also, veterans rated as fully disabled due to a service-connected condition. They're also do not have to meet the community engagement requirement. A person participating in a drug or alcohol treatment and rehabilitation program, they do not have to meet the community engagement requirement. A person who's incarcerated or who is released from incarceration in the previous 3 months does not have to meet these requirements. A pregnant person who's entitled to postpartum medical assistance, I should say a pregnant person or someone who is formerly pregnant who's entitled to postpartum medical assistance, and that's generally through 12 months following the end of pregnancy. An individual who meets the SNAP or TANF program work requirements does not need to meet these new Medicaid community engagement requirements. Now, this is the one where there's been kind of the most conversation about recently, and this, it's often referred to as people who are medically frail, and there's was further I should say, explanation of this in the regs that came out from the federal government, and basically they seem to pull back on earlier guidance they'd given to states around this area. But generally, it's an individual with a health condition that prevents work or other activities, and that piece that I've underlined there is sort of the important piece because that's where new emphasis was placed in terms of these regulations that came out. So things generally that meet this requirement are blindness or disability as defined by the Social Security Administration, a substance use disorder, a disabling mental disorder, a physical, intellectual, or developmental disability that significantly limits activities of daily living, and a serious or complex medical condition. Then how do you meet the community engagement requirements? Well, first, one way you can do it is you can work a minimum of 80 hours during a month, which can include unpaid work like caregiving, working in exchange for goods or services, or an internship. And one of the things I'd say here too is that Ohio has indicated that if a person has earnings of I think it's $580 a month, that they will be considered as having met the work requirement. And what's interesting, and that's based on the federal minimum wage. As most people probably know, Ohio's minimum wage is significantly higher than the federal minimum wage. And so in Ohio, having, $580 worth of earnings with Ohio's minimum wage would equal about 53 hours a month. So that's just something to kind of keep in mind when we think about work. Another way to meet it is community service, completing at least 80 hours of community service with a public or nonprofit organization, including governmental agencies or religious groups in the month. And the rules also say that the organization must not serve a partisan purpose. Finally, work participation programs. If you're participating in a recognized work or work training program for no less than 80 hours per month, the same for education, maintain enrollment in an educational program at least half time during the month. And then you can combine these activities. And when you look at all this, I think one of the things I come away with is just how difficult it can be to kind of keep track of all this, not just for the individual, but for our county job and family service offices or for the state Medicaid program. And so you can see how there could be a lot of confusion around this and how it might be difficult to track all this together. And I don't know if we still have a good way, particularly the community service portion is probably going to require a lot of paper. And paper is not a friend of Medicaid programs in terms of keeping track of things. So, what happens if a person doesn't comply? Their application for Medicaid coverage can be denied. Their Medicaid benefits can be discontinued if they're already enrolled. One thing to remember, if Medicaid denies an application or discontinues the benefits of an individual, they will receive a state notice explaining the decision and information on how they can request a state hearing if they disagree with the action taken on their case. And so this could kind of stretch out the time that it takes for a person to lose coverage if they've been notified that their benefits or coverage is either going to be denied or discontinued. The other thing to remember too, if a person is denied an application or their benefits are discontinued, they can reapply for coverage at any time and they aren't subject to a waiting period. So that's something to keep in mind as you run into people, in the next few months or next year that lost coverage, that they can reapply at any time. Now, of course, when they reapply, they still have to meet these requirements. Another important thing to keep in mind for people is if they're denied or disenrolled for noncompliance, they'll not be eligible for the advanced premium tax credit or premium tax credits that can help them pay for coverage on a health insurance exchange like healthcare.gov. So I think three things that sort of jump out at me as sort of Ohio implementation challenges. One is based on the state's own data from last year, we could be looking at more than 300,000 Group 8 beneficiaries that may require review to determine whether they are exempt or subject to the work and community engagement requirements. That's a lot of people. That's about 40% of the total Group 8 caseload. And those are people who either sort of meet that medical frailty definition or people that the state themselves acknowledged last year that they didn't have enough information about to know whether or not they might be exempt from the community engagement requirement. And I think the biggest challenge isn't writing the policy. It will be accurately identifying, documenting, and maintaining eligibility for hundreds of thousands of Ohioans. This is a big undertaking, and it's a big undertaking, sort of that's also combined with a lot of big other undertakings for our local and state Medicaid agencies, particularly like the 6-month redeterm for people in Group 8. So it's a lot, it's a big task. And new 6-month renewals, verification requirements, and outreach obligations will substantially increase administrative workload for state and county eligibility staff. They have a big job ahead of them, and I think we're going to talk more about that later. But I'll turn it back over to Tara at this point.
Thanks, John. Sorry, couldn't find my mouse on all the screens. I'm going to turn it over to Jesse now to dig into the details. I appreciate the level setting for us, John, and the challenges we have ahead. It's particularly important to understand what we know for sure as we are sort of applying what we have heard or what we've read in the interim final rule. There are lots of questions. So I think it's really important to connect the dots on here's what we know about how the Medicaid expansion population will be impacted. And then here are the many, many questions we have around what implementation will look like. And Jesse, if you are able to share your screen, I will turn it over to you and then I'll stay on just to let you know I see your screen.
Okay. Thanks. And I'll take a second before sharing my screen.
Sure.
Thank you, Tara. Thank you to the Center for Community Solutions. It's so good to be with all of you today. My name is Jesse Crosscall. I'm the Senior Director of Strategic Partnerships at Families USA. Perhaps more relevant for this call, I grew up in Cleveland Heights, so any time I have a chance to connect with advocates in Ohio, I really jump at that opportunity. So, hopefully LeBron James doesn't announce his decision in the next 40 minutes and we can just lock in on Medicaid for the time being. So if you haven't worked with Families USA before, we've been around for about 45 years. We're a national consumer healthcare advocacy organization. We work on programs like Medicaid, the ACA, Medicare, all around policies to drive down costs for consumers and expand healthcare coverage. Um, and then we also work closely with partners across the country, like the Center for Community Solutions in Ohio and so many other wonderful groups in the state. So, building on what John walked through, what I'm going to do today is just talk a little bit about how this rule that CMS released differs than what was in what was in HR 1, and that's relevant for this the public comment period that we're in. And then so I'll, then transition to talking a little bit about public comments and how all of you can weigh in and make your voice heard. All right, so now I will attempt to share my screen. All right. Can you see that?
I can see it. Yes.
Cool. Okay. So, one thing I'll say at the outset is that we at Families USA over the last 6 weeks have developed a bit of a go-to slide deck on this topic. So there's a lot of information in here. Some slides I may skip, but don't get overwhelmed by all the words and and everything on here because the intention is that we will share this after this webinar so you can have some more time to look it over when you have some free time. But as it relates to the comment period that we are in, a really important thing to understand is that the rule that CMS put out differed from HR 1 in some really key ways. And I'm going to really focus on two of those ways in this presentation. And they're both around this idea of medical frailty. John talked about medical frailty. This is a term that Congress just created around HR 1. This wasn't in the Medicaid statute. So just on its own, this is forging new ground to talk about this idea of medical frailty.
Jesse,
So,
sorry to interrupt. Can you put it on the slideshow mode just so it's a little
oh,
bigger?
yeah.
Thank
Okay.
you.
Sorry. Thank you.
All good. Thanks.
Yeah. Okay. So this idea of medical frailty is new. And since the law was passed a little more than a year ago, states have been at work using the definition that was in the law to tease these things out. And the medical frailty is really important here because it is likely to be a way, or should be a way, for a lot of people who aren't able to work 80 hours a month to nevertheless be able to retain their Medicaid coverage. As folks know, people on Medicaid, they usually come on and off the Medicaid program as their income changes, as their work situation changes. And of course, a lot of people on Medicaid have serious health conditions, and so Medicaid is a critical lifeline to them. So this medical frailty idea it will, apply to should apply to a large number of people within the expansion group. Okay, so I will move on from here. So again, the medical frailty on the left side of the screen, you can see how Congress decided it, or how Congress defined it. John mentioned all this. People who are blind and disabled have a substance use disorder, have a mental disorder. All of this makes sense. This sounds like if you were trying to define what the term medical frailty is, these are some things that would go along with it. But then, of course, it was up to the states to figure out how do you actually put this into practice? How do you figure out that Jesse, who has Medicaid coverage, whether or not he has whether he is medically frail because for one of these reasons. Now, we know that CMS had been working with states behind the scenes for more than a year and had been giving them sort of informal guidance on how to go about this. So states had been preparing for one reality. And what we had heard was that reality was that they would be able to take a lot of self-attestation. People who essentially were able to raise their hand and say, hey, I'm in treatment for substance use disorder, or, I am in treatment for cancer and I'm unable to work 80 hours a month. And that the states would be able to use that to exempt people from the work requirement. So CMS had been telling states that they could do that. At the last hour, right before the rule was put out, they put some more guardrails on that. Um, and also, just like as a data point in all this, there is one state, well, at this point, there are two states that have actually implemented the work requirement early. The first was Nebraska, and then at the beginning of this month was Montana. And we can see from the way that Nebraska was implementing the work requirement that they were doing it in a way that we anticipated that a lot of other states would. So what Nebraska did was they put together a huge list, hundreds of different codes from people who had gotten services through their providers. And so using those codes to match them with the people who use the service and then determining that they were medically frail. So, for example, again, if I went in for cancer treatment and the state had a coding as getting that treatment, then the state would be able to exempt me from the work requirement and I wouldn't have to do anything more. I didn't have to necessarily raise my hand. The state would just determine that I was exempt from the work requirement. The difference, and this is key, between what was in statute and what CMS is putting out there is that the CMS is now saying that states not only have to determine that a person has this condition, but they then have to, the individual has to prove that because of this condition, they cannot work. So what that means is not only if Jesse is in treatment for cancer, the state knows this, the state should be able to exempt me from the work requirement, but then the onus is on Jesse to go and find documentation saying that he is unable to work 80 hours a month because of that condition. So we will get in a minute, we'll get to where the burden for that falls. You can guess it's on providers and it's on the individual. So this is the key way that there is a difference between what was in statute and what is in this new rule that CMS has put out. So, one other place that is different, and this follows from what I was just talking about with regards to medical frailty, that in statute on the left, it says that the state can put together processes for using reliable information, like these codes that I mentioned, without requiring the individual to submit additional information. This is essentially what I was just talking about. So the but what the rule that CMS put out, they really clamped down on this idea of using self-attestation. So they said for the first year in 2027, states can accept self-attestation, but beginning in 2028, states can only accept that once for a person. So again, they're really putting guardrails on the ability of individuals or the state to raise a hand and say a person is exempt from the work requirement. All right. So this puts a lot of burden on states. One of the big ways, or one of the big reasons it does that is because, again, states have been preparing to set up one system, and now they have been redirected to go in a different direction with essentially 7 months until this program has to be up and running. So having to set up a whole program in a year and a half, which is a really compressed timeline. They were going in one direction. CMS said, no, you have to go in a different direction at the last minute. And so they're really under a time crunch here to set up all the systems, to, put out the regulatory framework, guidance to providers in the states, guidance to cities, counties. And this just walks through all the ways that this is really putting a burden on states. Now, there was money in HR 1 to support state implementation of these work requirements, but it was only going to be about $4 to $30 million per state, which is really a drop in the bucket for doing these big systems upgrades and system reconfigurations. And ideally, a state would be able to hire a lot more staff to process all of this, to like go through the hundreds of thousands of people that will be subject to the work requirement. But with that amount of money, that's really not enough for a state to do really anything at scale. And so, just like zeroing in on this, the burden on providers from all of this. So, providers, as you know, their primary interest is caring for their patients. They can do, they do their work best when they are able to be doctors, nurses, counselors, all of that. But when you are asking, but with these new requirements, they are being asked, both the providers, but also the clinics, the hospitals, and everybody else, to take on this burden of determining if a person is medically frail. So unfortunately, providers are going to be put in this situation for a lot, for their patients, whether they have existing relationships or new relationships, if that person is on Medicaid, to help a person navigate this process of determining if they're medically frail. Like I said, with this new requirement that a person not only that they be medically frail, but they are also able to document that they are unable to work, that's going to fall on providers to provide that information. And so these are just some more considerations for providers. There's doctor and nurse shortages in many parts of the country, the additional paperwork that comes on, the role for managed care organizations, how are we going to bill that time that providers spend doing all this new paperwork? It's a lot. So what I'm going to do now, maybe just close your eyes because I'm going to skip forward a few slides to get to the part where we talk about the actual comment strategy. So again, all of the slides I just went through, there's a lot more good information in there that that you can look over when we share the slides later. So, um, I will drop this in a chat in a minute, but Families USA has put together a guide for advocates on how to comment on this rule. So, a little bit about commenting on proposed rules. Usually, if CMS puts out a proposed rule, there's a 30 or a 60-day comment period. By law, they have to take comments from the public. And then when they finalize the rule after the comment period, they have to address those comments. So if a bunch of commenters are talking about this pain point or that pain point, if CMS changes that provision, leaves it the same or whatever, they nevertheless have to, in the final rule, discuss how they addressed the comment, either for good or for bad. This one is a little different. This is an interim final rule. So the rule is going to take effect on August 1st, regardless. Now, that might make it seem like there's no role for the comment period, but that's not the case. And the reason is, one, CMS can change what's in this proposed rule, or sorry, what's in this interim final rule. So they are feeling some heat from providers and advocates across the country already. So based on that pressure, we hope that they would loosen up some of their definitions around medical frailty and some of the additional restrictions they put on just because they're feeling that heat. But then also having a robust comment record can be used in a litigation strategy down the road. I'm not a lawyer. I don't work for a legal services organization, so I can't guarantee that there will be litigation. But if there is, it will be based on the comments that people submit during this comment period. I think people may have seen that there are 26 states that have already sued the Trump administration over this rule, and it is about the definition, or it's about the interpretation of medical frailty. So there's already one lawsuit out there. There potentially could be more in the future. So I would suggest, and I would urge that folks take part in the comment period. And what I'm going to do is just provide some tips on it, just to hopefully break through what goes into good comments and make it perhaps a little less daunting. So first of all comments are welcome. Families USA, we're going to submit comments. Ours will probably be 15 pages of single spaced comments, really nitty gritty Medicaid details. If your organization can do that, great. If not, that's totally cool. Individuals can submit comments. They can submit comments that are 1, 2, 3 sentences long. Um, so so basically, you don't have to, you can participate even if you're not doing long, detailed comments. You can do it as a coalition as well, where you work on it together and then all the organizations sign on their names. So what lawyers say is that both volume and quality are important. It's good to have volume of 10,000 comments were received, but also the quality of the comments are important. So it's a both and. The only thing that we would say or we would caution against is doing template comments or copy and pasting comments. So we would urge you against drafting a comment letter, sending it to all your partners and urging them to just swap their name in to the comment and keep submitting the same thing. The reason is that CMS does use AI tools to basically flag all those duplicate comments and just count them as one. So that will not help the volume question if you're just submitting a bunch of template comments together. So if you are going to comment, you should focus on who you are and what your interest in the Medicaid program is. That goes for an organization, that goes for an individual. So as an organization, you can talk about your work with people with Medicaid. You can talk about your people, even if you're not a healthcare organization, let's say you work with um, on hunger issues and the SNAP program, it's nevertheless a lot of the same populations. So you can talk about your work with this population. You can talk about how important it is that people in your community, the people you work with, retain their Medicaid um, coverage. So these are just some examples of how you can discuss a connection to the Medicaid program. You can talk about it, how the program serves pregnant mothers before and after they give birth, helping people manage chronic health conditions, making it easier to maintain employment because they're able to get healthcare coverage. But we encourage people to make their comments specific. So again, if you're an individual and you've had Medicaid coverage in the past and you want to just talk about how critical that lifeline was to you to as you were applying for your next job, taking care of whatever condition you had, that itself makes for a wonderful comment. Um, there's more detail on all of this in the guide that we put together. But if you want to go really detailed into the policy issues around this IFR, um, these are some places that you could look. These are all things that we have touched on in the course of this webinar, definition of medical frailty, challenge of documenting exclusions, the compressed timeline, all of these are good things to lift up. And again, there's more detail in the guide that we will share. And the final thing that I will say to close it out is that we at Families USA see this as an advocacy opportunity. Once your comments are ready and you submit them, we would encourage you to do something with them. We would encourage you to share with your partners over your channels, whether it's through a newsletter, whether it's over social media. This is a really good time to request meetings with your federal delegation, state lawmakers, state officials, to just walk them through some of these issues here. So if like for, your federal delegation, um, even folks who may have voted for HR1 might not understand how CMS has implemented this law differently than what they proposed, or than what they enacted. So this is a good time to just educate lawmakers, even if they are people who support Medicaid work requirements. And then, finally, if you can put out a press release, host a press call, anything like that, we want to make sure that this really critical issue is not lost and that people don't forget this huge change that is coming to people with Medicaid coverage. Okay, so I'm going to stop my share and turn it back over to you, Tara.
Thanks so much, Jesse. That was a lot of information, but very helpful to frame all of this and next steps and inform this group of folks who I know have really are connected in ways all over the state to encourage folks to provide comments. I do see we will get to the Q&A section in a minute, but I do see a question in the chat around using information from these slides on social media to help sort of, I guess, inspire folks or inform folks about how they can provide comments. I think we're always fine with that as long as things are cited. I think that's probably true for all of us in our world where we're sharing information so that it can help to equip everyone with the tools that they need to um, you know engage in that comment process. But I don't want to speak for Jesse.
That's fine. Just I will, fess up that the slides we put together are probably not pretty for social media. So encourage anyone who actually, is fluid in that area. But yes, feel free to take some of the information and craft it in a way that actually gets engagement.
Great, thank you. So let's move over to the Q&A box. I know some questions have come in throughout the presentations, and continue to submit questions here or in the chat where we'll get to as many as we can in the next 20 minutes. So I'm just going to move back to the beginning to sort of start there. One of the questions around disabled veterans sort of falling into the when we were talking about the exemptions and things around the work requirement, disabled veterans were specifically mentioned, and the question came up around whether they would be receiving services through the VA rather than Medicaid. But I imagine there's some like tricky overlap in some places, but I'll let John respond to that.
I guess I would say in many cases, but not always.
Yeah.
people in Ohio may live too far from a VA facility, or they may choose to get their care outside of the VA. So I think it's one of those areas where there's nuance, and but not everybody who is a disabled veteran gets their care from the VA, and there are a lot of veterans who are covered by the Medicaid expansion, particularly around Group 8. So
Great, thanks.
Yeah, and I want to just hop in here just to flag something, and this is just this isn't even really about the IFR. But John laid out all the different exemptions or the different groups that the work requirement doesn't apply to. But that doesn't mean that people understand that they are in one of those groups. One of the real
Yeah.
dangers of work requirements is like the mass confusion that is out there. And so just for example, as John mentioned, if you're a parent with a kid under 13, you're exempt. But if you are hearing that there are new work requirements, you have Medicaid coverage, you probably will not pick up on that nuance. You probably, and so we have seen this already. There's just like a lot of confusion when people hear that there's a new work requirement in Medicaid. They don't know whether it's going to apply to them or not. And the worry is that the default is that they think it will apply to them, even if not.
Yeah. Thanks, Jesse. That's an important point. And the message we've been pushing out is continue to apply. These are not in effect yet. Keep applying, but also once they are in effect, keep applying because we don't want to see folks lose coverage. We are starting to see some of the on the SNAP side where some of the changes have gone into effect already, directly impacting the folks enrolled. We are starting to see some drop off in enrollment, and we suspect that some of that is due to folks just, not applying or not going through the process of proving certain things, even though they may still be eligible. Moving on to the next question. Does a person have to engage in activities that meet the work requirements 20 hours a week, or can each week be less as long as it totals up to 80 in the month?
yeah, because under the federal rule, the requirement is measured on a monthly basis, not on a weekly basis. So the point is the 80 hours per month, not necessarily that they have to be even, so much per week over the course of a month.
Great, thanks. On the education component for the requirement, can the hours be quantified through attendance or does it need to be half-time enrollment? The person asking the questions thinking specifically around WIOA, who enroll adults around the state but don't state full or half-time for their enrollment.
I don't, Jesse may have ideas about this. I think this one's a little tricky because it's not really spelled out very clearly. And so this may be one where Ohio Medicaid has to kind of weigh in on this and sort of spell it out a little bit more clearly because that program is a little different. I don't know, Jesse, if you know anything further about that. So,
Yeah, I don't want to lead anybody astray on this.
yeah.
I do know that the Department of Medicaid was working to establish a connection with the National Student Database. I might not be getting that name correctly, but there is a database of folks enrolled in higher ed that they were going to try to establish and be able to have sort of that electronic or an easier path than turning in some paperwork to show that you're in school. I also had we had some questions in this space too around um, there may be some overlap with, as kids are sort of like coming out of 12th grade into higher ed, like that, what that data transfer looks like. So there are a lot of elements to this that we're going to need to keep track of as we're asking questions. Next question is around the connection on work requirements and moving into the health exchange. The way that this person it's Julie. She works with us. Hi, Julie. She understood that folks who don't meet the requirements are then not eligible for health insurance on the exchange. Is this true or just not eligible for the tax subsidies?
My understanding is that they're not eligible for the subsidies or the premium tax credits, so they can still purchase coverage. But I mean, the effect is, I mean, the cost of coverage in Ohio for a single person is probably in the range of $6,000 to $7,000 a year. So if they were previously eligible for Medicaid, it's hard to conceive of them being able to afford coverage, buying it without any subsidy.
Is there any information on how people can document their inability to work? Is CMS expecting medical professionals to write a note that says that the person can't work or do community service?
I mean, Jesse may have more information about this, but I mean, there's no requirement in the rules that says physician has to write a note. But then there's also no explanation about how you are able to prove that your medical condition by itself is just not allowing you to work or participate in the community engagement requirements. It's silent on it, but and the state really hasn't put out, I don't think, a sort of a clear definition of how people might be able to indicate that or prove that. I don't know, Jesse, what you think about that, or
Yeah, that's right. I think essentially the answer is yes. CMS is expecting providers to have a note that says people can't work. But this is a clear, this is the key thing. Um, CMS has put out this rule that says not only do you have to have not only do you have to be determined medically frail, but you also have to be determined that you can't work. It is then left up to states to figure out how to make that second part work, whether it's coming up with like a standard note that a provider can fill out and all of that. But then all 50 states, have now been sent off to do this project on their own. And the states are then going to be going back to CMS now over the next few months and say, hey, this is how we want to do this, and then CMS is going to give the up or the down. So, if you are working with state officials, this is exactly the kind of thing you should be asking about, and just like teasing out with them which direction they're going in. And if you have ideas on how to make this as least burdensome on beneficiaries and on providers as possible, definitely share that with your state officials.
the other thing I would add to this is, you know, not all providers are the same. Some providers, federally qualified health centers, community mental health agencies, safety net hospitals have large numbers of Medicaid patients that are get their coverage through the Medicaid program. And almost all of them in something like this will have to sort of figure out how this works through their workflow. They all use EHRs. They have their own set of tech questions that they're going to have to figure out about how they generate these notes, how they get them into the medical record and all of that. And so it's a really big undertaking, and it really places, I think, a particular burden on kind of our safety net providers, the folks who do the lion's share of work for people on Medicaid.
Thank you. There's a couple of questions around medical frailty that are here in the Q&A and in the chat. Um, I think sort of the overarching theme is this uncertainty around the medical frailty piece the most concerning? And then some of the questions here are asking around, is there a list? What does that look like? How can we sort of make the connection between, yes, there's um, medical frailty. I'm seeing one question here around medical frailty may mean you can do some jobs and not others. Are you going to be able to find the jobs you're able to do versus the ones you're not? So just sort of, I mean, maybe the question in here is what is most helpful to sort of document and include in comments around these questions, because it does seem very uh, complex.
Yeah, so to take a step back, and this is actually like a good question. This is a really good question for a couple of reasons. First, we've been focusing on this medical frailty thing because it's so important for the comments, because it is a place where the rule differs from the statute. And I'll come back to that in a second.
Yeah.
But if we take a few steps back, um, a large number of people, are not medically frail under any definition. And so please, as you do this work, just think about the work requirements in general and in total, and what a massive undertaking this is, and how hard it will be for individuals to navigate this, whether they are medically frail or not. So this is new. It's never been done in the Medicaid program. There was one state, Arkansas, about 8 years ago that tried it for a few months before court made them stop, and it was a disaster there. And so we are expecting large coverage losses across the country. And those coverage losses come because it's really hard to engage all the people with Medicaid to make sure that they understand these new reporting requirements that they have. So I know a lot of you were like involved in the Medicaid redeterminations when we cycled that off in 2022 and 2023, and how what a complex undertaking that was with advocates, providers, everybody across the healthcare spectrum to engage people in that redeterminations process. This is essentially that over and over and over again. So there should be, a real concerted effort by the state, by all of you to engage with individuals, tap those trusted voices within communities, whether it is providers, faith leaders, city officials. We know that the folks who are closest to people with Medicaid are the most trusted voices. So just think about that education about work requirements generally as a complex undertaking. Now, we've been focused on medical frailty because, again, that's a key place where the rule differs from the statute. And as far as a comment period where there could be litigation down the road, it's important to have a robust public record of folks flagging this discrepancy and all of that. So just want to make that like crystal clear that like the medical frailty isn't the only thing that's problematic here. And it isn't the only thing that's going to be a challenge.
Yeah, I guess I would add to that, Jesse. I mean, the people that we're talking about who are medically frail, who have these different conditions, they're the folks who need Medicaid the most. I mean, they're ill. So we want to make sure they maintain their Medicaid coverage. And, also, I think, when we went through the unwinding process after sort of the end of COVID with Medicaid, I think, folks can correct me, but I think in kind of about 50,000 people left the Medicaid program during that process. And so I feel like this is that on steroids because it is so broad and affects so many people and is so challenging, and it will create just I can't it will create a lot of errors in the program because it's just the nature of it, I think. So
Yeah, thank you. So I want to, there's a lot more questions. I don't know if we're going to get through them all in 6 minutes, but I did want to flag a few that are very related to the comments. So one question here is around um, that legal aids often combine comments with other legal aids and kind of submit them. I don't know that, they wouldn't necessarily look form like, but they work together. And the question here is whether it's would be more impactful or effective this time to do things separately.
I think if you have done this in the past and you have done it as a sign-on letter, by all means do the same. Like I said before, like both quantity and quality. So if you have really detailed comments from all the legal aid organizations in Ohio and you're all signing on to the same, that is awesome. And that's great. And
Okay,
yeah.
great. There's another question here around what's the biggest message. I would say from community solutions perspective, right now on July 15th, the biggest message from this is to provide comments. I think the question here is around, do we want to encourage them to stop any changes or increase staff to implement? I mean, both of those things are important, but I think like the train is rolling, right? So we're at this point trying to make what's happening have as much clarity as possible and work with, folks at the state and local levels in Ohio in particular, with our county systems, and then all of you and our partners across the state to make this least to mitigate harm, right? And um, we unfortunately are past the point of, I think, stopping this happening. Um, but I, would look to John and Jesse too to add anything there.
I think that's right, Tara.
Okay. I'm seeing a couple questions around like who to share comments with. Should we share them with state officials? I think yes. That's our plan when we do public comments. We of course submit them to through the formal process, but also share them on our website. We will attempt to get them out before July 31st so that if folks want to look at what we've written and use that as a helpful anything, they can. But I know that, most of us are happy to share our comments as far and wide as possible. There are some questions around the education component and sort of what pieces of that, getting some clarity around that. So, did GED courses count? How will that be proven since that wouldn't necessarily be in this like higher ed database? And then I saw another one around education. Sorry, I'm looking between the Q&A and the chat. Oh, there's a question around the volunteering piece too, a couple questions on volunteering and sort of like proving that. Can it count if it's part of a treatment program? So like if you're volunteering as part of treatment, my current sense is those are great questions and we don't have as long as the IFR, the interim final rule is, these are all things that you all know is happening in the world, and it's good to point out that we're going to want to know how to track all of this and understand how it's counting and what it's counting toward.
And I guess I would say, Tara, all those questions also be good things to include in the comments.
Yeah.
To talk about the programs you work with and how there's not clarity around, how people who are in those programs or engaged in those activities are protected. And
Yeah.
because they're certainly within the spirit, it sounds like, of what the law talks about. But I'd include those in comments, those questions.
Yeah, for sure. Let's see. We have 2 minutes. I think we can try to get to one more question. Trying to find one that we haven't touched on yet. Um, I see a question here about the role of managed care organizations in a lot of this and getting information out to enrollees and sort of what role they're playing right now. I don't know if there's any comment from John or Jesse on kind of what that looks like currently or what it could look like in the future.
I mean, I don't know what, I haven't talked to them recently to know kind of what they're doing, but I do think they have a role to play in, educating their enrollees, their members around these requirements. I know there's some limitations about, what they can or can't do, but I think there's plenty of opportunity for them to communicate with their members about what these requirements might be.
Yeah, great. Thanks. Well, we're at 10:59. There are a couple of questions left here that we will take back and share. I, as John mentioned, though, keep these questions at the ready to include in your comments because I think all of them are really very important questions to be asking when we have, um, such a complex thing to implement over the next few months. So I want to thank John and Jesse for their presentations, their guidance and their wisdom. Very much appreciate your time this morning. We will have the recording of this webinar as well as other resources linked on our website very as soon as we can, knowing that time is of the essence heading into the end of the month. So thank you all for joining, and we will hopefully connect soon. Thank you again.